Good evening, everyone. If this is your first time watching, welcome to our Life in Motion monthly webinar series. If you're returning, welcome back. I'm Caitlin, your host, and tonight we're excited to have Dr. Brown and Kaylee Stahler with us. Let me start by introducing Dr. Brown. Dr. Brown's a board-certified, fellowship-trained orthopedic surgeon who focuses on knee and shoulder injuries. Dr. Brown really understands what it takes to get athletes back to their peak performance after an injury. And he also knows how important it is for those weakened warriors to return to work quickly. In Memphis, he serves as the head team physician for Memphis Hustle and Harding Academy and is an assistant team physician for the Memphis Grizzlies. Outside of work, Dr. Brown loves spending time with his wife and 2 sons. He's passionate about giving back to the community and serves on several committees and boards that support youth, education, and medicine right here in Memphis, Tennessee. Now, let's introduce Kaylee Stahler. Kaylee is a registered and licensed occupational therapist with over 10 years of experience in orthopedics, specifically in outpatient care for upper body injuries. She's been a member of the American Society of Shoulder and Elbow Therapists since 2023, and her research has focused on topics around shoulder arthroscopies and rotator cuff repairs. In 2024, she presented on distal dysfunctions following shoulder arthroscopy, explaining why some patients experience neuropathies. Neuropathies are basically nerve-related issues that can cause tingling, numbness, or weakness in the wrist and fingers after surgery. Then in 2025, she shared on her work on rethinking the rotator cuff recovery, presenting clinical research conducted right here at Ortho South during the Society's annual national meeting in San Diego, California. When she's not at Ortho South, she loves to travel with her husband Andy and their 2 children, Ella and Avery. She's an amateur but a motivated tennis player, and there's nothing she enjoys more than a good workout. Well, except maybe a cup of coffee and a really good book. With Dr. Brown and Kaylee's insight and expertise in comprehensive and collaborative care for shoulder injuries, we're thrilled to have both of them navigate the roadmap on recovery, repair, and rehabilitation by bringing it back to the basics and providing step-by-step guidance for all of you watching. Throughout the webinar, Dr. Brown and Kaylee will be asking you some questions, a little game of trivia, if you will. When they ask you those questions, drop your answers of what you think in the comments. It's totally okay if they're wrong. I'll share a few of your responses out loud, and then we'll reveal the correct answer. And as always, feel free to submit your questions in the comments throughout the webinar. We'll be answering them at the end of the webinar tonight. All right, so without further ado, I'll turn it over to both of you.
I am so excited that we are finally doing this.
Firstly, I know I could speak on behalf of everyone live tonight. You're a busy surgeon, you're a family man, and I really, we all really appreciate your expertise as we navigate the roadmap to rotator cuff repair, which is a journey. We have a lot to cover tonight, so where do you want to begin?
Yeah, thanks for joining us. Very excited about this. This is one of my favorite topics, and it's my favorite surgery to perform. So this should be fun. Let's dive in. So I wanted to get started. Let's ask a question, a little trivia. How many muscles make up the rotator cuff? The answer is 4. And so this is a little diagram, and if you look at the diagram, it's labeled, there's an acronym SITS, S-I-T-S. There's the supraspinatus, the infraspinatus, the teres minor, and the subscapularis. Those names aren't really all that important, but the supraspinatus is the one that is the most commonly injured rotator cuff. But really, what does the rotator cuff do? The rotator cuff primarily is the stabilizer of the shoulder joint. So if you look, just to kind of step back for a second, anatomy lesson. So if you remember, ligaments connect bone to bone, and tendons connect muscle to bone. So that those red structures, that's the muscle piece, and that becomes a tendon that attaches to the bone. And those things, when the muscles contract, it pulls the humerus into the socket. And so really the primary function of the rotator cuff is stability. It stabilizes the shoulder. And in terms of function, it's a rotator cuff, so it helps you rotate your arms. And so if you look at this particular picture, it's a little bit shocking. If you look at this baseball pitcher,
I'll grab it real quick.
And it's a little bit shocking
Very
to see,
shocking.
but the shoulder is the most mobile joint in the human body. It can have up to about 270 degrees of rotation, and you can just see, look at this picture. And yet, with all that motion, it can also generate a force that can throw a baseball over 100 miles an hour. It's truly fascinating. But because of the increased mobility and because of the force that it can generate, it is definitely susceptible to injury, which is why many people have rotator cuff tears. And so the function, it stabilizes the glenohumeral joint, and it's very susceptible to injury.
I feel like that's so interesting. It's an interesting paradox that what makes our shoulders so functional, so mobile, is actually what makes it susceptible to injury, to damage. So let's say someone has shoulder pain, and a lot of shoulder pain, it really appears very similarly with different diagnoses. So at what point are you concerned about a rotator cuff tear?
Yeah, so there's really three things that I notice when I talk to a patient. So there's three hallmarks of rotator cuff pathology. Okay, so specifically with the tear. So one is pain in the shoulder that runs down the arm. Two is pain with reaching shoulder height or above. And three is pain in bed at night. Those are really classic symptoms, and really almost everyone has that with a rotator cuff tear.
Okay, and at what point, so let's say someone has these symptoms, and they've been, taking Advil, maybe they've been icing, a couple of days have passed. At what point are you recommending them to come and seek a consult with an orthopedic surgeon?
Yeah, so it's a good question. I get this a lot. I get tons of text messages and calls from just friends and family, and hey, my shoulder hurts, my ankle hurts, my knee hurts. When should I come in? Should you look at this? And typically, my answer is, my first question is always, is it swollen? Is your ankle swollen? Is your knee swollen? And if it is, then yes, you need to come in. The problem with the shoulder is the shoulder really hides swelling really well. You can't really tell when the shoulder is swollen. It has to be really bad to see the swelling.
What about bruising?
Bruising is another one. If you've had trauma and there's bruising, then that's cause for concern. So typically swelling, so I don't really ask that, but for shoulders, I will frequently ask, okay, so has there been trauma or not? So did this just come out of the blue, maybe working out, or was there an actual injury? So specifically with an injury, what I'm looking for is bruising. Mm-hmm. Number two would be weakness, and three would be loss of range of motion. So if you've had a trauma and you have significant weakness, loss of range of motion, and really even bruising, yes, I think you should come on in. And when I say come on in, I'll just give a brief aside that really orthopedic offices, like, we can take care of really everything. You don't need to go to the ER. The ER is just basically, they're going to put you in a sling and send you out. You break your arm, you break your shoulder, sling, send you out. You tore your rotator cuff, they're going to sling it and send you out. Really, the only thing the ER can do is help you with a dislocated shoulder, but we can diagnose that in the clinic, try to put it in the clinic, and if it doesn't go in, we can always send you to the ER. So that's just a brief aside. So just come to the office. I think that's the way to go. So if there's trauma, loss of range of motion, weakness, I think you should come in. If there's no trauma, say you've been working out, you've been doing Pilates, been doing CrossFit, if it's been 7 to 10 days, and it's just been hurting, ibuprofen, ice it. But if there's loss of sleep, I think that's really the time when you come in. If it's interfering with your sleep, sleep is so important. It's important for recovery. If you're losing sleep, I think that's when you should come.
Okay, so someone comes in. What are you typically doing that first visit?
Yeah, so everybody that comes in, we're going to get the same thing. So I'm going to talk to you. I'm going to find out your story. Every story is different. And I'm going to examine you, and we're going to start with x-rays. And typically x-rays are not super helpful for a rotator cuff tear. However, there is an instance where it's helpful. So if you look at the image labeled number 1 on the screen, that's a normal looking shoulder with a normal rotator cuff. And you can see the ball and socket joint. So right above that cursor is a space. Right there, and that's where the rotator cuff lives. The rotator cuff is doing its job in image 1. In image 2, if you notice, there's very little space above the humeral bone, the humerus, in what's called the top of the shoulder blade. And that's because if you remember from that picture, the rotator cuff pulls the socket into the joint. It's a stabilizer. And when there's a tear, the humerus can slip through that tear and the bone starts moving superiorly. And so x-rays are typically not helpful, but when I see that, that's a sign that you've had a rotator cuff tear for a year, 2 years, several years. And I really don't even need to get an MRI at that point. But the gold standard for diagnosis is always, it's an MRI.
Okay, and then at what point are you getting an MRI? Are you trying things first, or?
Yeah, so good question. So I think that if there's been trauma and weakness and you can't lift your arm, that's really going to be an immediate MRI. We need to know what's going on while that's happening. If you're just having some pain and it may just be tendonitis, we're going to try other things first. Maybe some medicines, some rest from exercise, physical therapy, or even a steroid injection. And so if you don't get better after we're doing those things, that's when we would think about getting an MRI.
Okay. And you're referring patients to therapy. Let's say when we talk about partial versus full thickness, are you treating those differently, or are you trying, some conservative management first with full thickness or only the partial thickness?
Yeah. So, the MRI, can you go back to that slide with the MRI?
Yeah.
So one more back. So the MRI, if you look on the left side of the screen, it says normal rotator cuff, and it's really pointing to the black area above the bone. And that's the tendon. That tendon is attached, it's touching the bone. If you look at the image on the right where it says fluid, that means the tendon has pulled off and it's been filled with fluid. That's a tear, okay? So the MRI will tell us the dividing line of how to proceed with treatment is every tear, every person is different. Every tear is different. Every snowflake is different. And so it depends on if the tear is a full tear or if it's a partial tear. Can you show the next one? So the one on the right where it says full thickness tear, that means that the entire part of the tendon has pulled off. There's a giant hole from where the tendon is on top and the bone is on the bottom. You can just see straight through into the socket. That's a full tear. Generally speaking, if you have a full tear and you've had a traumatic injury, I'm going to lean surgery. I'm going to be more aggressive with treating that. That's generally how that's going to go. You can try therapy, but generally speaking, it's going to end up in surgery.
Okay. How would you describe a full versus a partial thickness tear to your patients? Any good analogies that you have?
Yeah. So if you look at that picture again, Kaylin, so if you look at the partial tear on the left side, you'll notice that the tear there's a certain length that the tear is attached. And on the right, it's fully been ripped off. Where the one on the left, you can see that it's still partially attached and partially torn. And so the analogy I frequently say is it's like string cheese, the little tubes of string cheese that you'll pull off a little piece of string and then another string and another string. Well, that's what a partial tear is. You've had some of the strings come off traumatically or, over time they've pulled off. So this string cheese is, I think, a good example.
I think that's such a good analogy.
Yeah.
That's a good one.
And so when you start talking about treatment, I think that it really depends on the amount it's torn. So how big is the partial tear? Quote, how much string cheese has been pulled off of the tube? And so the important number is 50%. So if it's greater than 50% of the string cheese, then that's going to be more likely to need surgery. If it's less than 50% of the tendon attachment, then that's going to be more likely to succeed without surgery. And when we talk about surgery versus non-surgery, there's several options. And so I mentioned them earlier. So we might start with medicine. We might do a steroid injection. And we might end up talking about biologics. Everybody wants to talk about biologics.
Patients are very interested in biologics.
What are biologics? Biologics are things like stem cells and platelet-rich plasma. So Right now, those things they're labeled, experimental. They are not FDA approved. They are not covered by insurance. And so those are, out of pocket expenses. And, for full thickness tears, stem cells and platelet rich plasma injections, they can't bridge that gap when the whole tendon is pulled off. It's not going to bridge that gap, but there may be some use for these things with partial tears at some point in the future. We just don't know. Our research hasn't really proven that out yet. And so it's just classified in that experimental category. And so I don't really recommend them unless somebody really wants to try it and has the extra money to do that. But the mainstay of partial thickness rotator cuff tear is physical therapy, 100%. So Kaylee, what do you think? Tell us about what's therapy like for a partial thickness tear.
So for partial thickness tears, we really are focusing a lot on strengthening. So I think, when that becomes an issue, if someone's so painful, it's gonna be really painful to strengthen. If they don't have any good functional range of motion, it's gonna be really hard for them to strengthen. So I think the perfect candidate is someone who's maybe had an injection, or maybe their pain is controlled with anti-inflammatories, and they're in this kind of sweet spot where they're pretty pain-free. Maybe they have the night pain, but their range of motion is good. They're pretty functional. Those tend to do really well in therapy. A lot of good response to KT tape too. I think that's very helpful.
What's KT tape?
It's an athletic tape that we can place on various parts of the body. I use it a lot on the shoulder. But what it helps do is it helps to lift the skin and increase blood flow. I also find that patients, especially with known tears, find a lot of support in KT tape. You could shower with it, you could swim with it, you could sweat in it, just don't rip it off too fast, it can burn. Yeah, it's not so fun.
Yeah. When do you feel like, when is the vibe that when this is going to work or not? Surgery, no surgery. What's the time frame?
I usually can tell right away at that first encounter if a patient's going to do well or not. But I typically tell them, let's stick around for 4 weeks, at least 4 weeks. And then let's see how you're doing. And if they're really not having any significant progress, then I'll usually send them back to you. It's nice, you're down the hall, it's really easy to collaborate. Usually by the time they see you, it's not much of a surprise. You usually know how they're doing by that point. But I'd say, be patient 4 to 6 weeks. And I also tell people it's not going to be magic, right? They're going to maybe have some slight improvements. Maybe they can sleep a little better. Maybe they can work with a little bit less pain. But it takes time to fully get better. But I'd say 4 to 6 weeks is a good time frame for some improvement.
That's good. And yeah, you touched on one thing that I really enjoyed, and I think it provides better care is, sometimes doctors will do the surgery and then they'll go do therapy an hour away. And the doctor never talks to the therapist, never speaks to nobody really knows what's going on. It's not collaborative at all. And we really do work down the hall.
Yeah, it's
so
just easy.
We're
really spoiled.
We're very spoiled. Just like you said, I really already know how somebody's doing by the time they come back because I've already talked to you about it.
Right.
It really does make care back. So, all right. So let's say they did get better with therapy and they're happy.
Yeah.
But if they didn't get better with therapy, then you sent them back to me.
Right.
And I have the discussion about surgery. And we decide to go ahead and do it. They book their date. And then tell us about what happens from when they book their date until surgery day.
Yeah, so we just started a brand new initiative of, it used to be that the patient would wake up in the recovery room and they're in this sling. They really don't know how it got on them or how to take it on, how to pull it off, when to take it on and off. So ideally, if we could see the patient pre-operatively before surgery, and we could fit them for the sling just to make sure it's a proper fit and they feel comfortable, and they also feel comfortable with taking the sling on, taking it off. A lot of straps that can get a little confusing for patients, and then I usually provide a lot of education. It's a great time to just sit down. They have a lot of things going in their head. They just found out they're getting surgery, and it's usually a really stressful time. They have a lot of questions, and I could also talk to them about things that can make their life a little bit easier after surgery. It's going to be hard.
Kaylee, you're showing the sling.
Yeah, that's a nice fit for a sling. A lot of patients have questions like how should their elbow be, and how should their neck be, and I'd say every body type is very different, but you want to make sure that abduction pillow is there, and that, your wrist is supported and not hanging off, but also that you have the ability to function, and that your neck is not too much strain on the neck. That's a common complaint too. So we fit you for the sling, we answer a bunch of questions, and then we can talk about things that will make your life a little bit easier after surgery in terms of pain, and functional ADLs, just like how am I going to do things with one arm? So there's a lot of problem solving. I'll say it's like a session to problem solve. There's these snap shirts. I don't know if you could show them up there. Yeah. Great. A lot of my patients already come in with them and I get really excited. Like, oh, they figured it out on their own. But they have them on Amazon, and they snap. They have different like colors and long sleeve, short sleeve.
You want to show them the video?
Yeah.
How easy it
play
is?
that video. Yep. So much easier. And just like things like, maybe getting an ice machine, figuring out how you're going to sleep after surgery. A lot of patients sleep in a recliner or at least propped up with a lot of pillows, maybe a wedge.
Yeah, probably 10 years ago or 5 years ago, I had a patient come in after surgery and they were frustrated with getting dressed and everything else. And they said, Dr. Brown, I got it. I've got the best idea. We're going to start a new company. We're going to do this together. And they're calling it these snap on and off shirts. And it's just going to be fan. We'll sell it on Amazon. It's going to just, it's going to explode. And I had to tell them that it was already
Did you show them the link?
Yeah, so that business didn't really work.
It is a good idea though, don't you wish?
It's a fantastic idea.
So now hopefully the patient is somewhat ready for surgery. Maybe if you could talk us through what happens day of, like they get to the surgery center, what could they expect in the OR?
Yeah, so most everyone is able to be done in a surgery center, so you don't have to go to the hospital. You get to go home and sleep in your own bed. When you get to the surgery center, you get checked in, get vitals, get a gown on, and that whole process takes about an hour, hour and a half, and then you will be in surgery about an hour, hour and a half, depending on severity. Sometimes it can be shorter, sometimes it can be longer, and then you'll be in recovery in about an hour or so. So it's a full morning, afternoon. It's several hours. It's a half-day process. And then before you go back to the operating room. You typically get what's called a nerve block, and this is like an epidural when women have babies. It just helps deaden the nerves when you've got the spinal cord, and then there's these nerves that peel off, and you get nerves that go to the shoulder, and then the elbow, and the wrist, and the hand. And so the nerve block deadens the nerves that go to the shoulder. And during the nerve block, that sounds extremely scary if you're putting a needle at the base of my neck.
Yeah, is that painful? It sounds painful.
It's so the anesthesiologist will give you some medicine, and the medicine is it's really almost like amnesia medicine. It makes you very relaxed. It makes you feel very good, and you don't really remember anything afterwards. And so, but the whole procedure, takes 5 minutes. There is a needle. It's a little bit of pressure, but again, you don't really remember it happening. And it is fantastic. It's really revolutionized pain control after rotator cuff surgery. It really helps for a good 24 hours where most people don't even need it.
So their arm is like a dead arm, essentially? Like they cannot wiggle their fingers?
They can't wiggle their fingers. Okay. They can't feel anything. It's fantastic after surgery, but it's a spooky feeling.
I'm sure a lot of patients talk about the nerve block, like they're just very spooked out by it, or maybe they feel numbness, tingling after continued. Is that typical?
Yeah, I wouldn't say it's typical, but it can happen. The numbness and tingling typically goes away within a day, but it can last sometimes weeks, but it's never really a long-term problem.
Okay, and then do all of your patients get nerve blocks?
Yeah, I would remember, maybe one, 10 years ago that just opted against it, and you don't have to get it, but you will suffer, through afterwards. It's a tough deal, and I just try to encourage people that if it were me or my wife or anybody in my family, I would definitely encourage them. They would get a nerve block. I think it's very helpful.
There's a few questions in the chat asking about if the nerve block is painful or not, because you asked them.
Yeah. So it's like I tell people when I get any injection, it is a needle, and so it does hurt a little bit. But again, the happy medicine really does make you happy. It gives you amnesia. You won't really remember even getting it. And so it's just more, it's more pressure. It's really not bad.
Okay. So walk us through maybe a little bit of what's going on in the OR and who's in there and what are y'all doing in there?
Yeah, so I think first you'll see on this picture that it's not just me in a room. I mean, it's a team of people, for you. So if you look at this picture, this is Tim on the right, and he does the anesthesia. He puts you to sleep.
Is he there the whole time?
He's there the whole time, and he is your friend. You don't feel anything because of him.
Yeah. We like Tim.
We like Tim.
Yeah.
And then next is Claire, and Claire is with me during all my surgeries. She helps with holding the camera, with suturing up at the end, passing sutures, just generally making sure, helping me with the surgery. Next to Claire is Angie, and Angie is we call the scrub tech, and she is a technician that really passes instruments. When I say I need a scalpel, or when I need scissors, or when I need X, Y, or Z, she's the one passing it to me, so I can focus on the patient, focus on you, while she can focus on the instruments. So it's a team, and then not even pictured is the nurse circulator, and she's the one that if we need extra suture, or if we need an extra gauze, or if whatever we need, she can go get that for us. And so it's really a team of 5 people in the room for the patient. And let me go back one right fast, Kim. I just want to show that you can see the arm. The only thing that's exposed is really the shoulder. Your face is covered, your legs are covered, everything is covered except your shoulder. All right, let's go to the, and then so in terms of what actually happens, so rotator cuff surgery is really arthroscopic.
Has that changed since you've been practicing?
Yeah, so it's 25 years ago or so, there was a lot of people doing open surgery or even mini open rotator cuff repair. It's really transitioned where almost everyone is doing arthroscopic, which arthroscopic just means minimally invasive, small incisions. I am sticking a camera inside the joint and then projecting that onto a screen. So if you look on this picture, it says the camera view. So oddly enough, when I do surgery, I rarely look at the patient. I'm looking at the screen, and my hands are doing the work. And so it's not a robot. I mean, I'm actually controlling the camera and moving the instruments. And then there's Claire beside me to the left. And if you look, it says traction. That's important to know. So you're on your side, and there's a bean bag. It's a semicircle bean bag that helps hold you on your side. And then through a pulley system, we pull your arm, and it's, several pounds of pressure in your arm, and it distracts the joint. It opens it up so I can do the work I need to do. Not only do I distract it, but we fill it with fluid, and that fluid pushes all the structures out so I can see everything the way that I need to see it. And so it really is, I mean, you don't want to say it's a video game, but it really is projected onto a screen.
Upscale video game, yeah.
And then I will say too on that picture, go back to it. I mean, it's really like if you put a movie on at your house at night, like you turn the lights off. Like we really do. I operate with the lights mostly off. So it's just I can see the screen a little bit better that way. Yeah, that's really what happens. And so specifically in terms of the surgery.
Yeah, like what's your technique?
Yeah. So let's play the video.
Yeah, let's play the video.
So this is actually from one of my patients. This is me with an instrument in my hand. And the white structure on top is the rotator cuff, and down below is the humerus. And so it has ripped off the humerus. And this is me with the instrument putting that back down. You want to watch that one more time? So I'm showing the hole. That's a full thickness tear. That's not partial. And that's putting the rotator cuff back down to bone, lifting it up, and putting it back down to bone. And so it takes a little bit of time to get all that exposed to make sure that it's just how I like it. And then the picture on the left So how is it actually repaired? Everybody asks this, everybody. So inside the bone, I put a screw, and we call it an anchor because it's anchored to the bone, but it is really a screw. It's not a metal screw. It's a material. It's almost like a plastic material called polyether ether ketone, and it's literally screws in. I mean, it's about 2 centimeters, and it goes straight into the bone, and its sutures are connected to the middle of it, and you can see the sutures going straight up and down in that left picture. And those sutures get, just like when you sew up your shirt or your pants, the sutures go through the tendon and you suture it back down to the bone. And so you can't see it all on the right-hand side, but that's a completed repair. Where if you notice the tendon is no longer in the air, it is reattached to the bone, and those blue sutures are pushing the tendon back to the bone. And there's a second anchor and a second screw on the outside or lateral part of the shoulder. So there's 2 screws anchored into the bone with sutures pushing the tendon back down. And that's all done, arthroscopically, which is just small incisions. There's no big incision that's done or that's made.
Really cool.
Yeah, it's definitely a big advance from years and years ago of opening the shoulder up. It's a slick little technique. So, and it is all done with small incisions. So if you had to guess, how many incisions does it take to fix a rotator cuff?
All right, yeah, let's wait and see what people think, how long it takes. All right, we've got 3 weeks, we've got 5 weeks, I believe, 4 weeks, 3 weeks.
Just incisions.
Yes.
So,
Oh, I'm so sorry.
the short
I was
answer-
given the wrong unit.
The short answer is you are all correct. So it really depends. Typically it's going to be 4 to 5. It can be 3. It can be 7. It's really, like we talked about earlier, no tear is the same. We all have different personalities. Every rotator cuff tear has a different personality. And so it really depends on what I need to do. So if it's a big tear, I'm likely going to have more incisions. If it's a smaller tear, I'm going to have less. But my standard is 4 to 5 incisions, and they're about 1 centimeter. And if you look on the left-hand side, you can see the shoulder. This one had 5. So there's some stitches that are still in that you can see, and they're just dotted around the shoulder.
They're so small. They're honestly hard to find. Like later when we're doing arm massage and stuff, I'm like, trying to find the incisions. They're really small. It's incredible how far we've come.
Yeah, and so Kaylee, when they come back for their first 1 week, they come back for their post-op visit.
Right, that's when you're taking out the sutures.
That's what I was going to say.
Yeah.
So what happens in that right-hand picture that when they come back and see you on their first post-op visit?
Yeah, so sutures are out at the first post-op visit, and then you would come to see us, and we're really taking that time to again sit down, chat about what to expect going forward. A lot of people are like, oh, I took all my pain meds, anticipating that we're going to be doing tons that day. But the truth is, there isn't tons we could do. They're only 1 week post-op. I always am stressing, right now is time for protection of the repair. However, all these other adjacent joints are also immobilized. Your elbow, your wrist, your neck, everything's kind of in the sling, and they didn't get repaired. So that's a really good time to start moving the elbow, the wrist, the neck, the shoulder blades. We do a lot of shoulder blade mobility that day, that's really what to expect first day. We start ice. If we haven't started it at home, we started at home first. We talk a lot about pain control, but yeah, we're not doing anything with the shoulder that day. So.
Yeah, and we'll get into, I think, some therapy specifics in a little bit, but I'll talk a little bit about, everybody asked about pain control immediately after surgery. Rotator cuff it's a very successful surgery. The first 2 days are pretty tough. It's a tough road. It's a tough hill to climb, and everybody gets through it. Everybody does really well, but I really talk to patients about having a schedule. I think people do much better if they know a plan, before they get into trouble. And what I mean by trouble is that if you get behind the pain then it's really hard to get it back ahead. So it's like a snowball. If you're behind the snowball, there's no way you're getting out in front of it. If you're behind it, it's tough to get out in front. And so I talk about, you can take pain pills every 6 hours. At the 3-hour mark, I talk about taking ibuprofen. So it's pain pill, ibuprofen, pain pill, ibuprofen. Really every 3 hours you're getting something, and generally do that for the first, after the block wears off, for the first 2 days. Staying ahead. If you stay ahead, it's so much better.
When do you find that people are typically weaning from those harder pain medications?
So I found that for 2 to 3 days, most people need the medicine and take it regularly. After 2 to 3 days, it's much more what they're doing. It's activity related. So I think 2 to 3 days on a schedule. After that, it's just as needed.
Mm-hmm. That's good to know. Yeah.
And so when they come back the first week, speaking of pain, do you talk to them at all about sleep?
Absolutely, yeah. We're talking a lot about sleep. Because I'd say that's like, if I had to think of one thing that everyone talks about the first time, it's I can't sleep. How am I supposed to sleep? I'd say that's like the universal, symptom. Unable to sleep. It's awkward. You're in a sling. You're uncomfortable. And we talk a lot about sleep in our recliner, sleeping, maybe with wedged up pillows, and then maybe removing a pillow a week, I think the first little bit, pain is really, it's really intolerable in terms of the sleeping and the resting pain. That's when patients are feeling most pain, not when they're in there moving their elbow, but later when they're trying to sleep. So I always am telling patients, even as we go along, yeah, your pain will change, but also maybe, icing right before bed, or taking maybe something over the counter right before bed if you need. And then maybe, stopping the exercises, maybe doing exercises in the morning and then in the afternoon, and then maybe not doing exercises for 2-3 hours before you go to sleep.
Yeah. So as we dive into the rehab, part of this, I think a lot of people have questions about, well, should I do this? Should I do that? What do I do? And so I thought it'd be fun to, maybe let's go through some don'ts, do's and don'ts.
I love that. Do you want me to do or don't?
I'll be the mean doctor.
Okay,
I'll be the don't section.
Okay.
And so the first thing, after surgery, we talk about don't move your shoulder.
Do move your elbow and your wrist.
And we'll dive in a little bit more to this as we get into the rehab.
Yeah.
These are some rapid fire. So
remember these.
Number 2, don't drive until you're cleared to drive.
But do enjoy being chauffeured around Memphis.
Don't bathe or submerge your incisions.
But please do shower.
Don't remove your sling.
You can take it off for showering and also for exercises once you're instructed.
Don't ever use heat.
Don't use heat, but do use ice frequently.
And then most importantly, Kaylee's favorite one is don't ever skip physical
That is
therapy.
my favorite one. I want to say it again, don't skip therapy.
Don't skip physical therapy.
But do everything your therapist tells you. Second favorite one.
That's exactly right.
Yeah.
Just do whatever she says.
Yeah.
So, and then specifically getting into the, rehab phase. So that you've had the surgery, all the, the big stuff is done, and now this is the grind. This is the we're getting you back to normal, to being you. And so there's the big picture is there's 3 big phases. Can you go back one, Karen? There's 3 big phases. So one is the 0 to 6 week phase, and that's really we're just protecting the repair. You're in a sling. Very important. We want the tendon to heal to the bone. Phase 2 is week 6 to 10, and we call that the functional active motion, where you're out of the sling and you're actively moving your arm. And then the 3rd phase is at 10 weeks when we start to strengthen you, and that's kind of the fun part of therapy.
Yeah, that's really fun.
But let's dive in a little bit more. So, Kaylee, tell us a little bit about that first phase, that 0 to 6 weeks. So you've already talked about the first post-op, getting stitches out, pain control, sleep, helping the sling, getting that off and on. What else? What's happening from 0 to 6?
0 to 6, you can expect just passive motion of the shoulder. So I think it's important maybe to talk about passive versus active, active assist, and then, ultimately strengthening. But if there's no passive mobility in the joint, well, it's going to be really hard. You might be able to activate, but you won't be able to move through gravity. So the idea is we want to make sure that there's some mobility in the joint, so that way when at 6 weeks we have time and we have worked hard on your passive motion so that you can activate when it gets to 6 weeks. So passive motion, really important. It's going to be kind of graded. So we start off with just a gentle pendulum, and it's exactly what it sounds like. You're just letting the arms swing, and you're not activating. You're thinking about momentum, your trunk, your legs, doing all the work, and your shoulders kind of, I tell people, it's coming along for the ride. I think they hear me saying it's coming along for the ride, like for the first full 6 weeks, like every time they see me. But it's true. For every exercise, your arm is coming along for the ride. It's like a dead arm. I think that's hard not to contract musculature during some of these exercises, but it's a little bit of an art.
Which of the patients don't move their arm for 6 weeks?
Well, something is moving their arm. So it's what, further down the line, it's a pulley system. We use like dowels, canes, large balls, towels. I move their arm, but yeah, they are not actively moving their arm for 6 weeks. It's a long time. So, but there's a lot we can do. So it's kind of like walking on this tightrope of there's a lot we can't do, but there's also a lot we can do, and it's important to do the things that we can do so that when we can move on to 6 weeks, we're ready, right? Because you're going to say, all right, time to ditch the sling and do more. If you've been sitting in a sling for 6 weeks, there's not much we're going to be able to do.
Yeah, there's some controversy within rotator cuff repair of, should you start therapy early? Should you start later? If you start later, you have a tendency to get stiff, and if you start early, there's a tendency for the rotator cuff to not heal. And so it's a little bit of a balance. Tell us about your research that you've been doing, that you did about a year ago.
Yeah, so about a year ago, and before that, we were seeing patients more, what do you say, like the 4-week mark is about right. And they were coming in, and maybe their elbows were a little stiff, their shoulders were certainly stiff. I think they were, in a lot of pain still at the 4-week mark. Dr. Brown agreed to get patients in a little bit earlier. So we started getting them in at the 1-week mark about a year ago. And then I kind of just gathered all the data of, hey, well, how is this working out? Are we seeing patterns where patients are improving? Patients were off their pain medication a little bit earlier. They had better passive motion early on. They were able to, easily transition to those different phases that we talked about, the 3 different phases. You're able to more, smoothly transition from phase to phase, having started therapy earlier. Again, we're not moving the shoulder any earlier per se, but they're starting therapy earlier. They're getting in, they're moving all those adjacent structures we were talking about, and ultimately it just gives us more time and together to problem solve, and then also to work on your passive motion and your active elbow motion and your neck. Patients are just doing a whole lot better, I think. Do you think?
Yeah, from my perspective, it's been a game changer.
Yeah.
It's really been good.
It's been huge.
And you got to present this research at a big national meeting in San Diego, right?
San Diego in October.
So I've loved it. Patients have done so much better with starting a little bit earlier. Now, we're still not moving the shoulder,
Right.
but we're just working everything else around the shoulder, and it's been so much better.
Yeah.
So that's weeks 0 to 6. We're in a sling, can't move the arm. What happens from weeks 6 to 10?
Okay, so then they see you, right, 6 weeks, and we're done with the sling, and now we're doing a lot more in therapy. And then I think they're also doing a lot more in their daily life. Now they can actually move their shoulder, still no weight bearing, still no dumbbells, no resistance, no lifting Amazon packages off the doorstep. But they're able to do other light tasks, brushing their hair, brushing their teeth, getting dressed. All these things that we kind of just take for granted that they haven't really been able to do independently. Now you can do them independently. I always tell them, don't be surprised. I think patients are surprised by how little activation they have, but we expect that. Been in a sling for 6 weeks, so it's going to be hard to do a lot of these things. It's not going to be easy to get behind your head and do your hair, especially not first week. But I think that's where we see a lot of great improvement is those 6 to 8 weeks. Patients can start to activate. They can start to reach high in their kitchen cabinet. They're starting to see the light at the end of the tunnel a little bit at that point. What did you say?
Yeah, my two favorite days are at 6 weeks when you get to get rid of the sling.
Yeah, they're so
It's
happy.
a big day.
So happy.
And then graduation day when
Yeah.
everything is done, they just give me a big high five. That's those are my 2 favorite days. So 6 to 10 weeks where they're starting to move around, they're getting back into life, and then tell us about 10 weeks and beyond. Like, what is that about there?
10 weeks and beyond, they're fun, and we get to use bands. We can use some dumbbells. We're starting to really strengthen. I always start with like the bigger structures. Think like bicep, like big back muscles. We're starting to strengthen those first before we get to smaller musculature of the rotator cuff. So we go from that to the rotator cuff strengthening, and then I'm probably going to say this a lot tonight, but everything is progressive. So you don't want to start strengthening up here if you haven't strengthened laying on your back. So I always start off, you're laying on your back, you have a very light dumbbell, or you're standing up and you're kind of in this plane. You're not in this plane. We'll get to that plane when this plane becomes a little bit stronger. So everything's progressive in terms of even 10 weeks we could strengthen, but we can't go back to the gym doing what we were previously doing before the injury. But we'll get there. Just takes time.
Yeah, I always think about 10 weeks and beyond, especially once you hit that like 4-month mark. I always think of it's like a Rocky movie. I envision Kaylee with the patients that Rocky has a trainer that's just like getting them ready. They're doing push-ups and therapy.
Yeah.
They're doing
Some patients are like, I couldn't do this before. I couldn't do this before surgery. It's like some things they're hard, and it's really cool to see someone going from this very vulnerable stage of the sling, and they're just not sure there is a light at the end of the tunnel. And then especially that 10-week mark, when they're able to really do some of the things that they love doing, working out, it's really challenging not being able to do these things that you love to do. And suddenly they're kind of getting back into the swing of things. It's nice to kind of see them getting back to their tasks that make them happy.
Yeah. What do you think, what makes a good therapy patient after rotator cuff repair?
I think that sweet spot of they're not too cautious, but they're also not too free to make their own decisions. In terms of, I think a lot of people, especially at the beginning, maybe they're not in a lot of pain. The rare blessed ones, they're not in a lot of pain, and then they feel like, because I'm not in a lot of pain, like, why can't I just activate my arm? So it's like not taking those liberties, still listening to the protocol, but not being overly cautious, because we don't want to deal with like postoperative stiffness, and a lot of apprehension also doesn't lead to a good outcome. So I think the perfect patient is this patient that isn't too cautious but isn't too free. They're like somewhere right in the middle.
Yeah, I agree completely.
Yeah. And then they do really well. That's the thing I love about rotator repairs also. It's like the type of thing that if you listen to us and you listen to the protocol, you're gonna do well.
Yeah. If you're a little too bit of a free spirit, that's a problem.
It's definitely a problem.
If you're nervous Nelly, that's a problem too.
Mm-hmm.
You just want to be in the middle.
Yeah. Trust the process.
Yeah, definitely trust the process. And I think that's it. Maybe we should entertain some questions.
For sure.
Do y'all want to ask your last question?
Oh yeah, we have lots of
Yes.
Well, actually, we did talk about this, so let's ask the question and let's see if it's a
It could be like the pop
little bit of a trick question.
There you go.
So how long do you think it takes for a tendon to heal the bone? So if you think of it in terms of, I'll let you answer and I'll just keep talking. If you think of it in terms of the different phases, so the first phase is passive, and that's the 6 weeks, and then 6 to 10 weeks is active. And then at 10 weeks, there's some strengthening. And so what do you think the answer is? What are they saying?
We've got 10 weeks.
Got some good listeners.
We've got 1 year.
1 year.
We've got 4 months. 1 year. 1 year.
Yeah.
I want to reveal it.
Yeah. So the answer is all the above. So a little bit. So the trick part of it is that it's healed enough at 6 weeks to be able to lift the arm. So against gravity, it's healed enough. And these are biomechanical studies that have been done. And at 10 weeks, it's stable enough to start to load it, to strengthen it. And then, so that's, but the 1 year, the studies have also shown that you will improve after a rotator cuff for up to a year after surgery. But people are in the gym at 6 months, and you're in the gym at even 4 months. getting back to where they want to be. So there's a lot of correct answers.
Yeah, I think a year is actually a nice marker for, I think a lot of patients are, I still feel like, stiffness in the morning, or I still feel, pain with, a year is probably a good marker of like, when will you remember yourself prior to injury, maybe a year.
Yeah, I think so.
Okay.
Yeah.
Dr. Brown, do you want to give your speed analogy?
Oh, yeah. I mean, I think that when you finally get cleared in physical therapy, and that can be anywhere from 4 to 6 months. I just tell people when they're getting back into there, say they want to get back to CrossFit, which you can. I mean, we expect everybody to be back to 100%. We expect everybody to do everything they did beforehand. But it's just like going 0 to 60. We don't just go 0 straight to 60. We don't do the same workouts. You go start by going 0 to 20. And then when that goes well, we go 0 to 40. And then when that goes well, we go, up to 60. So it's just progressive, like Kaylee was talking about. You just got to be smart about your recovery.
Awesome. Let's turn it over to the audience for questions. This one kind of ties in. When can you start swimming? And is swimming a good way to recover?
Such a good question. Do you want to answer?
Yeah, so there's 2 layers to that. So, I would say that, so just in terms of an incision standpoint, this goes for any surgery. I really like the 3-week mark for getting into the water. It just takes time for skin to fully heal. We don't want dirty bath water or pool water in our bodies. And so I usually just for incision about 3 weeks. For getting into the water and actually swimming. So, the overhead motion freestyle is very stressful to a shoulder. And that's just not going to happen before 4 months. Now you can get in and do, a breaststroke and get in there after 6 weeks. You can do motion, for 6 weeks. But in terms of really getting back and swimming laps, freestyle, that's really good. I don't really want that happening until 4 months.
Is it a good way to recover?
Absolutely, yes. Swimming is excellent. I love swimming. The key is you just have to do it right. If you get in there and you start providing resistance in the 6 to 10 week mark, then that can pull the repair off. We don't want that. But if we're just using it for motion, because it's always easier to move in water than it is. Yes. Then it's great. It's an excellent way to recover.
Why would a doctor, this is kind of looking at the treatment options, is there a reason why a doctor would not repair the full tear of a bicep tendon?
So, I will say that number one, that's the benefit of if I'm in the shoulder and I'm doing a rotator cuff surgery, then I'm going to fix whatever needs to be fixed. And if the biceps needs to be reattached, then, I'll do that. I mean, it's a bigger discussion, different topic of which bicep needs to be fixed and what doesn't. But if it needs to be fixed, then absolutely it should be fixed during your rotator cuff surgery.
Awesome. Can a partial tear heal on its own? If so, how long will it take?
I'll take this one too. Sorry.
Yeah, please take that one.
So partial tears, once they're torn, it's a little bit difficult for it to reattach itself. Again, if it's less than 50%, it's still strong. It can still do the work. And you have 3 other tendons that can do the work of the shoulder. And so you have compensation from the other tendons. There are Major League Baseball pitchers with partial tears that are still pitching in the major leagues. And so you can have a tear and be very functional. In terms of, the time frame of it, I think Kaylee mentioned this earlier that, research will show 6 to 12 weeks. And if you're not better with a partial tear, then that would be surgery. I found that we really know after 4 to 6 weeks. If you're getting better, it's going to be obvious. And if not, then we're going to push more towards surgery. So I would say on that, it depends on how big the partial tear is the biggest determinant.
Gotcha. We have a lot of comments just praising both of you guys for the care y'all provide. One, Miss Lisa Rucker, she says, listen to Kaylee and do your PT.
Lisa, thank you.
We like Lisa. We like Lisa.
All right. And then let's see, we've got, do you think do you have any opinion on stem cells 6 to 12 months prior to surgery if it helps with recovery?
I think my short answer to that would be, I would hope so, but we just don't know that scientifically. There's just, we can make correlations. I've definitely had patients that say that they felt good and they've done much better after having stem cells, but the answer is we just don't know based on the data.
All right, so with work, Ms. Dorothy asked, how long after a full tear can you return to CNA work, such as like picking up bodies or pulling and pushing? So if y'all want to kind of expand that to.
Yeah, I'll just do like a big picture on, getting back to work. So if you have a desk job and, you can figure out typing because you're in a sling for 6 weeks, you really can get back to work whenever you feel like it. So some people are able to, hunt and peck emails, a few days after surgery, but I tell people 1 to 2 weeks if you have a sit down job. If you have a job that, remember if you walk a lot, so when you walk, you're pulling at the arm, you're pulling at the repair, it's jostling the shoulder. And so I don't really want you walking for speed, really for, honestly, 6 weeks. Strolls are fine, but for speed, I really don't like people to run for about 10 weeks because that's stressful. Running is really generating a lot of force to the shoulder. So if you walk a lot, I tell people, plan for 2 to 3 weeks. That's off of work. But then it really is a game changer if you do CNA work where you're lifting patients. I mean, that really is, unless you have help, it's probably around 4 months. I think some people can work around it with if their work environment's good at about 3 months.
Yeah.
They can get back if they get help.
For her job.
All right, next question is, how long does a rotator cuff repair work? Is there like a time frame on it when you need another one, or how does?
It's all for you. I'm so happy.
Forever. If we're gonna do it, we want it to work forever.
All right, next.
Then there's not a time frame on it. It should,
it
should last.
It heals.
It
You
heals.
need something else to happen for it to tear again.
Another like trauma.
Yeah.
So it is possible to tear it again, but it wouldn't be the same injury.
That's correct.
Gotcha. All right, next question is, how does losing weight or gaining some muscle before surgery help? Does it help at all?
Yeah. So I'll just keep rolling.
Yeah, you're doing great.
So,
Keep it up.
I think that it goes back to the anatomy. So if the first question we asked was how many muscles make up the rotator cuff? There's 4 of them. So typically 1 or 2 are going to be torn. And so if we can maximize the strength of the other ones that are intact, that are not torn, that just tremendously helps your rehab. It's doing the job of the rotator cuff while the one that's been repaired actually heals. And so I would call that prehab. It's like doing rehab before surgery and getting those other muscles strong, because that's fantastic.
All right, Kaylee, this may be for you. Mm-hmm. You talked about a lot of different ways in therapy you help patients regain strength and mobility. Miss Alicia says, during the strengthening stage, so 10 plus weeks, do you think that battle rope training would be a good idea to strengthen her shoulder? That's like the ropes.
The battle rope is the thing.
Ooh, like that. Okay. Not at 10 weeks. Yeah, never on the same page about that. Yeah, no. I just learned what that is today, and I say not at 10 weeks. We can get to that, but that's a pretty intense activity. So I'd say you need to gain a lot of strength elsewhere to be able to do that safely.
Yeah, I would say those. I didn't know they're called battle ropes, but that's more like when we talk about the 0 to 60. That's a 60 activity. That's not a 20 or a 40. That's usually, that's maybe about 4 months.
Awesome. All right. Well, everyone is saying thank you guys so much. Outstanding care team. This has been very helpful. Explained so much. Do you guys have anything you want to close with? Anything you want to leave if you have current patients watching, or just anyone who wanted to learn more about the rotator cuff?
Go ahead.
No. You've been doing great. We'll keep it up.
So I would just say that, a lot of people talk about rotator cuff surgery, and it really gets a bad rap. And it's a tough process. but it's an extremely successful surgery, and people can do really well. The best people are the ones that just follow and trust the process. If you do that, you're gonna have a good result and you're gonna do well.
Yeah, having the right expectations, which was essentially the purpose of the webinar, but having the right expectations.
That's right.
And listen to the people that are
Yeah.
experts in this field. Listen to your
skip physical
therapist.
Don't, yeah, if you take away one thing, it's don't skip physical therapy.
Awesome. Well, thank you everybody for watching. And thank you, Dr. Brown and Kaylee, for both being here tonight. And if you would like to make an appointment with Dr. Brown or any of our other providers at Ortho South, there'll be some information in just a moment for that. But thank you for watching. Y'all have a great night.